So this is the second video for our flagellates. Now we move on to the blood and tissue flagellates. So these are the members of the clinically significant group of parasites that are located in the blood and tissue of the host. They usually move just like the other flagellates with the use of the locomotory organ, the flagella. So these are known also as the Hemoflagellates, and usually there are two genus that are associated with this family, and that would be the Leishmania and Trypanosoma species. So here are the learning objectives for this topic. So identify and correctly describe the characteristics and diagnostic features of our parasites. Also to learn the life cycle and the mode of transmission and the clinical significance of each parasite. Also to explain the importance of prevention and control, and as well as to know which proper treatment should be given for each disease caused by our parasites. So here is the outline of our discussion for this video lecture. So we're still under the subphylum Mastigapora, but we will be focusing our attention to the class Zoomastigophora or the flagellates, specifically the blood and tissue flagellates. So under this, we have two genera that we will be discussing. So we have the Leishmania and the Trypanosoma species. So for morphological characteristics, your species under this particular class are still under the flagellates. So their main locomotory organ would still be the flagella. And what is unique for this particular species is that they contain or may contain four morphological forms. Okay, so we have the amastigote, promastigote, epimastigote, and trypomastigote. So let's discuss each one of them. So the first morphological form is the amastigote. So your amastigote is roundish to oval with an eccentric nucleus, so somewhere in the border, a dot-like bleroplast or blepharoplast, a small parabasal body, and an axoneme. Okay? And this is the morphological form that do not have a flagellum. So usually these particular forms may be seen in tissue cells or in the bloodstream as well. So here is a sample picture of our amastigote. So very distinctive of not having a flagellum in their morphological form. So the next morphological forms is what we call your promastigote. So your promastigote is slender, single nucleus with an anterior kinetoplast, but the most important one here is the presence of already an anterior flagellum here. Okay, so the flagellum is located, or a single flagellum is located at the anterior part of the parasite, and this is usually the infective and a unique stage of Leishmania species. So only Leishmania species have this particular morphological forms. So the next one is what we call the epimastigote. So your epimastigote is slightly longer than your promastigote, and it contains a posterior nucleus with a half of the body undulating membrane. So this is what separates it from your promastigote, with the presence of your undulating membrane. Remember, in your previous discussed morphological form, the promastigote, wala siyang undulating membrane. So for epimastigote, this is very unique, okay, with a half of the body length undulating membrane. So it also contains an anterior flagellum, and that is your epimastigote. So the last morphological form is what we call the trypomastigote. So your trypomastigote may be seen in the peripheral blood smear as C, S, or U in shape. So later on, papakita natin yung itsura nila under the peripheral blood film. So very unique to your trypomastigote is that, okay, compared to your epi, your trypomastigote has a full body length undulating membrane. So as you can see here, the undulating membrane almost covers the whole body of the parasite, and also contains a posterior kinetoplast with an anterior flagellum. So take note also that your trypomastigote is the infective and also the unique stage for trypanosoma. So your trypomastigote is only seen in the Trypanosoma species life cycle. So here is an example picture of our trypomastigote seen in the peripheral blood smear. So as you can see here, S-shape with a posterior nucleus and an anterior flagellum. So here is a sample picture to highlight the differences of the four morphological forms for the hemoflagellates. So now we're on the lesson proper for our species under the hemoflagellates. So the first genus that we will be talking about is what we call the Leishmania species. So your Leishmania species are classified into groups or what we call the complexes. And for each complex, there are probably multiple species behind this particular parasite. So let's move on. So for the easy understanding of the lesson, I have divided our Leishmania species based on their geographical distribution. So the first column, we are talking about the Old World species, and the only complex that is associated with them being distributed to Asia, Eastern Europe, and Africa is what we call the Leishmania tropica complex. Next, for New World, or the Americas continent, or the American continent, we have Leishmania mexicana and Leishmania brasiliensis as the parasites associated with this geographical distribution. So kindly take note all the countries that are associated with this particular geographical distribution. And lastly, we have the cosmopolitan on the third column, and only Leishmania donovani complex is associated with the parasite being distributed all throughout the world, okay, or worldwide distribution. So just a quick history check. In 1903, William Leishman is the first one to identify the intracellular Leishmania. So based on his surname, the identity of our Leishmania species are created or established. So now let's move on to the pathology of our Leishmania species. So for the pathology, it's very important to at least understand the concept behind the diseases caused by Leishmania parasite. So sometimes the Leishmania parasites may have multiple pathology, or their diseases cause may overlap from one species to another. So your pathology behind your Leishmania species is what we call Leishmaniasis. So it is categorized into 4 types of categories. And the first one, we have your cutaneous Leishmaniasis. So based on the first word itself, cutaneous, so this involves the skin, which is presented with a localized ulcer at the bite site of the vector. So just a bird's eye view of the life cycle for Leishmania parasite. The mode of transmission is through the bite of the particular vector or insect vector. So later on, we have different types of vector for each parasite. So your cutaneous Leishmaniasis is the most common form of the disease, and usually is caused by several species under your Leishmania. So the incubation period ranges from 2 weeks to several months, and an erythematous papule, or what we call the localized ulcer, is present on the bite site where the particular vector, okay, was located. So usually, the lesion have raised edges and a central crater, especially during the course of the chronic stage of the disease. Okay, a violaceous ulcer is very evident for in the host. So the lesion may heal spontaneously after a few months, leading to a disfiguring scar. In the case of our New World Leishmaniasis, okay, your cutaneous Leishmaniasis may progress to other forms of Leishmaniasis, which we will be talking about later on. So the next classification for our Leishmaniasis is what we call the diffuse cutaneous Leishmaniasis, or DCL. So in this particular scenario, the manifestation of your DCL is according to the immune state of the person, or what we call the anergic state. When we say anergic, this is the inability of our body to produce an immune response, or to, in layman's term, to fight off, okay, the particular parasite. So the usually the risk factor or the risk demographics that are usually affected by this particular category is those people with a low immune response, such as people with acquired immunodeficiency syndrome, or AIDS. Usually, this is maybe misdiagnosed by lepramatous leprosy, or what we call the bacterial leprosy that is caused by your Mycobacterium leprae. And the only thing that we can differentiate it from your other bacterial diseases is through diagnostic procedures such as immunology and serological tests. So this particular category is described as a localized, non-ulcerating papule that eventually develops into numerous diffuse satellite lesions. So as you can see here in layman's term, yung isang single ulcer, kumalat siya sa buong katawan ni patient. So ibig sabihin yan, the patient wasn't able to fight off the particular parasite. So ang nagawa ni parasite is nakalat niya yung kanyang species all throughout the area. Okay? So the next category for Leishmaniasis is what we call the mucocutaneous Leishmaniasis, or MCL. So your MCL involves the mucous membranes of the nasal and oral cavity. So just like here on this picture, as you can see, this is still considered cutaneous disease. So the infection is visible with the naked eye, but this particular category is associated with the destruction of the tissue surrounding our nasal and oral cavity. Usually, MCL is associated with the L. brasiliensis complex. At around 2 to 5% of the people infected with L. brasiliensis develops into mucocutaneous leishmaniasis. But as I have said a while ago, your MCL, the Leishmania pathology or diseases may overlap from one species to another. So another example of disease or parasite that may progress to mucocutaneous is your L. tropica complex. So kindly take note of these associated parasite. So patient infected with mucocutaneous leishmaniasis may experience nasal stuffiness, nasal bleeding, or what we call the epistaxis, and nasal discharge. So when it comes to MCL, these have an increased Th1 response. Your Th1, or specifically your THCD4 cells, okay, have increased in their, or are increased in the bloodstream of people infected with MCL. That's why later on our screening test for Montenegro skin test, this particular category is increased or positive. So kindly take note later on once we discuss your Montenegro skin test. And according to the book, your MCL have increased mononuclear cells in the bloodstream. So examples of mononuclear cells, we have your lymphocyte and monocytes. So the last category for our leishmaniasis is what we call the visceral leishmaniasis. And this is usually associated with L. donovani complex, which affects the bone marrow, spleen, and liver. Hence the name visceral leishmaniasis. So it affects the visceral organs of the body. Usually this is considered a disseminated parasitosis. So that means the parasite have invaded all throughout the body of the host. And usually it has an incubation of around 2 to 8 months. So very chronic. And usually mostly associated with people having an immunocompromised state, such as people with AIDS, or acquired immunodeficiency syndrome. So the manifestation of the disease stems from the spread of parasite into the visceral organs. So here is a general life cycle of our Leishmania species. So your Leishmania are acquired via the bite of an arthropod vector and usually targets the lymphoid tissue of the skin. Okay, these particular tissue are associated with the lymphatic system where the parasite are usually seen. So the vectors are sandflies in the genus Plebotomus and Lutzomia. So most of the time for these flies or sandflies, they're also associated with geographical distribution. So for Plebotomus sandflies, these are usually seen in the Africa or geographical distribution of Africa, Asia, and Eastern Europe. For Lutzomia, these are more associated with transferring the parasite in the Central and South America. So the infective stage for our Leishmania species would be the promastigote. Okay? Diagnostic is usually a mastigotes or the the initial or the origin of our parasite, that are usually seen in tissues, okay, ingested by macrophages, but they can also be seen in the bloodstream as well. So here is the life cycle of our Leishmania species. So as you can see here, the sandfly taking a blood meal will introduce the promastigote, the infective stage, to the human host. Usually, this promastigote may reside in the bloodstream or also in the lymphoid tissue of the host. So inside our tissues and bloodstream, macrophages are present. So these are phagocytic cells. Now, these phagocytic cells, since they one of their function is to phagocytize or eat the microorganisms to kill, these cells will ingest the promastigote stage, where inside them, the promastigote will develop into a mastigotes. So as you can see here, our parasite is immune to being killed by our immune cells, okay, or macrophages. So inside the macrophage, your promastigote will transform into a mastigotes, and after some times, your mastigotes will multiply and eventually burst out of the cell to invade other cells and invade the bloodstream in general. So during another blood meal, so a suspected vector will ingest, okay, these types of cells or the mastigote, okay, harboring the mastigote stage. Now, inside the vector, mastigote will transform into promastigote again and eventually divide and migrate to the proboscis or to the mouth of the vector. So the cycle continues once the vector infected with promastigote eventually take a blood meal to another suspected victim or person. So for the diagnosis of our Leishmania species, we can acquire samples of lesion and tissue scrapings, aspirates, and even tissue biopsies. I forgot to add here, we can also use your blood samples for the presence of your mastigotes. So the procedures that we can use is your GEMSA and hematoxylin eosine staining. This is to highlight the different nuclear details of our parasite, especially the mastigote. We can also use the culture for the for increasing the viability of our parasites, and also use diagnostic testing. This is mostly helpful for our non-cutaneous Leishmaniasis, or what we call the visceral Leishmaniasis, which do not manifest cutaneously. So most of the time, these are used with blood sample or serum sample, such as your ELISA and polymerase chain reaction or PCR. We can also use animal inoculation, but this is quite controversial since we are using live animal in the procedure. And usually, this animal inoculation is done through studies or research. So one of the screening tests that we use in the categories of Leishmaniasis is the Montenegro skin test. So this type of skin test is done by intradermally injecting Leishmania antigen, or what we call the Leishmanin, in the forearm of the patient. So the principle of the test is that if an individual who had been previously infected with Leishmaniasis, specifically your cutaneous and mucocutaneous Leishmaniasis, a delayed type of hypersensitivity reaction results in a measurable induration at the injection site, just like here on this picture. If you want to be more specific, at around 5 mm for 48 hours, this is considered positive for cutaneous and mucocutaneous Leishmaniasis. So the indication of this test is that if the patient has this particular induration, that means that their immune system had induced an immune response, giving immunity to the patient to progress to your other severe types. So the patient is immune to progressing to DCL and VL. So that means the patient is healthy and had created your Th1 type 4 or type CD4 plus T cells. So that means the CL and MCL have increased sensitivity to this kind of antigens. For negative results, we have your DCL and VL, or visceral Leishmaniasis. So that means that these patients who have been infected with this Leishmaniasis do not have a capability to be immune if should they be infected again by Leishmania parasite. So that means the possibility of having another Leishmania attack is possible for negative Montenegro skin tests. So the next test is what we call the RK39 antigen dipstick test. So it uses the principle of rapid immunochromatography. So very the same with our home-based pregnancy testing kits. So this is mainly for the diagnosis of visceral leishmaniasis. In this part, we are trying to look for the antibodies of the patient who have recently infected with visceral leishmaniasis. So the specimen is serum, and we just submerge the sample pad of the dipstick test into the sample of the patient, such as serum. So if the positive result connotes a double line, okay, at the control and test area of the dipstick test, just like the home-based pregnancy testing kits. So for the drug of choice for the treatment of leishmaniasis, we use sodium stibogluconate and N-methylglucamine. For the prevention, we use insect repellents and spraying of houses and buildings, especially for vector-borne rich areas. So now we're done with our Leishmania, the general information about Leishmania. So let's move on to the parasite themselves, okay? So let's move on to the first complex. We have your Leishmania tropica complex. So this is represented by Leishmania tropica, Leishmania aethiopica, and Leishmania major. So when it comes to the epidemiology, your Leishmania tropica complex may be geographically distributed all throughout the Old World. Hence the Old World parasite or Leishmania. So these are more commonly distributed in Africa, such as for aethiopica, major for Middle East, and some parts of Africa as well. L. tropica in Asia, India, and also in the Middle East. So in the Old World. So take note also the vector that is usually present in this particular complex. So that is your Plevotomos sandfly. When it comes to the reservoir host, although humans are the definitive host, reservoir hosts can spread, okay, these type of parasite from one person to another or from one species to another. We have the rock hyrax, a type of a rodent, gerbils as well, a type of rodent, and possibly even dogs. So now let's go to the pathology behind our Leishmania tropica complex. So your Leishmania tropica complex is the causative agent for the Old World cutaneous leishmaniasis. So for L. tropica, this is also known as dry or urban oriental sore, Baghdad, and Delhi boils. So all of these have the same clinical manifestation, just like here on this picture, okay? So they only have different types of names based on the place, okay? They are more common. So for L major, this is also known as moist or rural oriental sore. Okay? So this particular disease, just like we have discussed in your cutaneous leishmaniasis, this is presented with an oriental button at the bite site of the patient. So normally, the particular oriental button progress from a simple inflammation within the area, just like here on this picture, until it becomes violaceous, okay? Until the tissue surrounding the bite site become violaceous or become an open wound, okay? That means that the tissue had already been dissolved due to inflammation, okay? And multiple hypersensitivity reaction in the site. So take note also the different incubation period for our Leishmania tropica complex. So for L. aethiopica and L. tropica, both of them have the same incubation period, no? So the clinical symptoms may be presented, okay, within 2 months to 3 years. While for L. major, as little as 2 weeks, the signs and symptoms may be present already in the patient. So the next one is your Leishmania mexicana complex. So if L. tropica is the Old World complex, your Leishmania mexicana complex is considered the New World Leishmaniasis parasite. So these are represented by L. mexicana, L. pifanoi, L. amazonensis, L. garnhami, and L. venezuelensis. Okay? So when it comes to epidemiology, your Leishmania mexicana complex is associated in the New World. So this is in the South and Central Americas. So for L. mexicana, kindly take note of all the countries, okay, that is present or that are associated with this particular parasite. L. piphanoi is more common in Amazon River, especially in Brazil. Amazonensis as well. Garnhami and Venezuelensis for Venezuela. When it comes to the vector, the most common vector for sandfly is your Lutzumia. For reservoir hosts, vary the same. Forest rodents and other types of wild animals can also become reservoir hosts for these particular parasites. So the pathology behind your L. mexicana complex is what we call the New World cutaneous Leishmaniasis. So this is still a cutaneous Leishmaniasis but geographically distributed in the New World or in the South and Central Americas. For L. mexicana, this is mostly the causative agent of Basor and Chiclero ulcer. This Chiclero ulcer is named after the farmers, okay, that uses or that harvests the chiclero or chicle sap that is used for medicinal purposes, and most of the time this is also used for bubble gum, okay, creation of bubble gum. So according to studies, the farmers, okay, who harvest these chicle sap are also the vector areas where Lutzumia are present, okay, the sandflies are present. So farmers are more susceptible in contracting the chiclero ulcer. So very the same, just like here on this clinical manifestation. So for L. piphanoi, this is mostly commonly associated with the reactivation of your Cl to become the diffuse. Okay, this is for an opportunistic parasite, especially if the patient has a low immune system, okay, to become diffusely or to create satellite lesions all throughout the bite site of the patient. For L. amazonensis, this is may progress as well to DCL, but this is the type of DCL that cannot be cured, okay, an incurable DCL or diffuse cutaneous Leishmaniasis. So again, when it comes to your cutaneous Leishmaniasis for New World, this is still represented by a single pus containing ulcer, just like here on our picture, which is generally self-healing. So since we talked about your DCL or your diffuse cutaneous Leishmaniasis, let's have a recap about this particular disease. So your DCL is a non-ulcerating papule that eventually develop into numerous satellite lesions, just like here on this picture. Most of the time, this is more commonly located in the face, okay, and in the back of the person, where these are more open to vector bites. So people with low immune system are more prone to progress with this kind of illness or Leishmaniasis. Next one is your Leishmania brasiliensis complex. So this is mainly in the Brazil region, okay, which are comprised of your L. panamensis, L. peruviana, and L. guyanensis. So this is still geographically distributed in the New World, okay, your South and Central America. For Brasiliensis, Mexico to Argentina, L. panamensis, Panama and Colombia, L. peruviana, Peruvian Andes, and L. guyanensis is Guyana, Brazil, and Venezuela. When it comes to the vector, please take note of this. So for the vectors for Leishmania brasiliensis complex, Lutzumia and Psychodophagus is the sandflies or vector that are associated with the life cycle of this particular complex. Dogs and other foreign rodents may become reservoir hosts. So when it comes to the pathology of L. brasiliensis complex, this results in a very serious complication or a category of Leishmaniasis, and that is your mucocutaneous Leishmaniasis or MCL. So just like we have discussed a while ago, your MCL involves the mucous membrane of your nasal and oral cavities. So signs and symptoms usually felt by the patient is nasal stuffiness, nasal discharge, and also nasal bleeding or what we call epistaxis. Most of the time during the progression of this particular disease, patient may result or may have what we call the nasal disfiguration or espundia. Okay? This is where the particular area in our nose becomes disfigured and may progress to into the pharynx and larynx or your respiratory tract. So most of the time, signs and symptoms may manifest as dysphonia or change in the voice, dysphagia or difficulty in breathing, and even aspiration pneumonia. So some of your species under your Berzeliozis complex may also have different names, but still very similar when it comes to the clinical manifestation. So for Berzeliensis, this is espundia, just like here on this picture. Your uta for L. paroviana, and Forestio or pianboy for L. guyanensis. And lastly, for Leishmania, we have your Leishmania donovani complex. This is by far the most pathogenic of all the Leishmania species. So this is represented by L. donovani chagasi, L. donovani, and L. donovani infantum. So when it comes to your L. donovani complex, these are usually distributed all throughout the continents, no? So they don't have any specific type of world, okay? They may be distributed to different types of countries. For L. donovani chagasi, this is more common in Americas, specifically your Central America. For donovani, parts of Africa and Asia. For donovani infantum, this is more common in Mediterranean Europe, East Africa, and also in other parts of Middle East. When it comes to the vector, these are more specific to each type of species under this complex. For donovani chagasi, Lutzomia is the most common vector. For donovani and donovani infantum, Plevotomus sandflies are more common. When it comes to the reservoir host, these may interchange from one species to another, but mostly common are dogs, cats, and other feline types of animals. Okay? Kindly take note all the reservoir hosts indicated on the table. So, just like what I have said, this is the complex that results in a very serious complication of Leishmaniasis, and the most the most serious complication for Leishmaniasis is your visceral Leishmaniasis. So this is also known as your Kala-Azar, Dum-Dum fever, or black fever. Usually this is called black fever because of the blackening of the skin. Okay, usually felt or seen in patient with or infected with visceral Leishmaniasis. Again, just like we have discussed a while ago in the general introduction, your visceral Leishmaniasis is what we call the disseminated parasitosis. So this is where our parasite had already invaded the different visceral organs of our body, such as your bone marrow, spleen, and liver. So this is usually results in a 95% mortality rate, especially if the patient, did not consult or did not seek medical intervention. So signs and symptoms for acute, this is usually associated with double quotidian fever or 2 times fever spike within the day. Okay, so like for example, at 8 a.m. there is a fever spike. At around 4 p.m. on the same day, there is also another fever spike. So that is your double quotidian fever. For chronic, this is the signs and symptoms are more severe, having fever, weakness, and loss of appetite. No, weight loss may also be associated, and hemorrhage within the visceral organs are prominent. No, just kindly take note also that when it comes to the macroscopic examination of the patient, abdominal enlargement associated with hepatosplenomegaly is observed, just like here on this picture. So just take note that when it comes to your visceral leishmaniasis, a patient who recovered on this disease may progress into post-Kala-Azar dermal leishmaniasis. So this is a complication of your visceral leishmaniasis where recovered patient usually manifests with macular or macropapillar or even nodular rash in the skin of the patient. So just like here on this picture. So this is a complication of the patient, okay, who recovered from this type of disease. Okay, when it comes to the pathology, the particular pathogenesis of this PKDL is not well studied by scientists. Okay, but kindly take note that this is a complication. So patient who recovered from VL may have higher chance of contracting this type of disease. So we're done with Leishmania. So finally, we're on the last genus of our discussion for Hemoflagellate, and that would be your Trypanosoma. So your Trypanosoma are associated with two types of species, and that would be your Trypanosoma cruzi and Trypanosoma brucei complex. So just a quick history check. In 1895, the first one to identify your Trypanosoma brucei complex is David Bruce. So, in 1909, Carlos Chagas is the first one to discover the Trypanosoma cruzi species. So, this usually is the causative agent of Chagas disease based on the last name of the discoverer. So, let's move on to the first species. We have your Trypanosoma cruzi. So, when it comes to the epidemiology of Trypanosoma cruzi or T. cruzi, this is a parasite distributed in the Americas. Okay? So, hence the name or the pathology American trypanosomiasis or what we call the Chagas disease, named after the discoverer of the particular parasite. So, for the parasite biology, kindly take note that all the morphological forms are present in a life cycle of this parasite, your Trypanosoma cruzi. Take note of a mastigote which is present or found in tissue cells and also in the vector. Trypomastigote is the unique stage and also the infective stage for Trypanosoma species, which are usually found in the bloodstream of the patient. Promastigote and epimastigote both found in the vector and are not well studied due to the fact that these morphological forms are in the vector, okay, or in the insect vector. So, the life cycle of Trypanosoma cruzi is acquired via the bite of an arthropod vector. So, very similar just like in Leishmania species. So, the target organ is the myocytes or the tissue cells surrounding the myocardium of our heart. Reticuloendothelial cells or the tissue cells surrounding our tissues may also be involved in this particular life cycle. So the vector is the redobid bugs under the genus Tryatoma, Panstrongylus, and Rhodnius. But the most common one is the Tryatoma redobid bugs. Infective stage is the metacyclic trypomastigote or basically trypomastigote. Diagnostic stage is a mastigote and trypomastigote as well. So here is a unique life cycle of Trypanosoma cruzi. So take note that this the mode of transmission is very similar to Leishmania. So a vector, specifically your Tryatoma bug, takes a blood meal in a suspected patient. Now in this process, the Tryatoma bug introduces the metacyclic trypomastigote or trypomastigote in general. So this infective trypomastigote will be injected into various cells of the wound site or even travel to the bloodstream to attack the myocytes or the tissues of our heart. Now, inside our tissues and cells, your trypomastigote will become a mastigote where they will multiply by binary fission. So as you can see, very similar sila when it comes to Leishmania in a way that they need to penetrate a specific cell or a specific tissue to become a mastigote. Okay, this amastigote stage becomes the stage where they multiply by binary fission. Now, after multiplying, this intracellular parasite, okay, the amastigote will transform into trypomastigote again. Now, this trypomastigote will burst out from the cell and enter the bloodstream. Of course, if another blood meal is taken into place, okay, by getting bitten by a triatoma bug, so this triatoma bug will harbor the trypomastigote, which are present in the bloodstream of the infected person. Now, this trypomastigote will eventually evolve or develop into epimastigote, where they multiply in the midgut and becomes metacyclic trypomastigote. Now, this particular stage will eventually continue, and if the suspected person is bitten again with a triatoma bug or a vector. So, the pathology behind Trypanosoma cruzi is, again, what we call your American trypanosomiasis or Chagas disease. So, your Chagas disease is divided into an acute and a chronic type. So, for acute, this is characterized by a focal or diffuse inflammation. So, usually, the non-specific target of this particular parasite is the myocytes of our heart, or the tissue cells within our myocardium in the heart. So usually, the non-specific symptoms is associated with having fever, malaise, nausea, vomiting, and general lymphadenopathy or enlargement of our lymphatic system or lymph tissues. So cutaneous manifestation may also be observed and usually observed at the bite site of the vector. This is characterized by having a induration and a central edema within the bite site. Sometimes, parasite may also reside at other areas, specifically in the eye area of the patient. So normally, this is also known as Romania's sign. And this Romania's sign is characterized by having an eyelid swelling, okay, or conjunctivitis surrounding the eye area of the patient. So usually after 1 to 2 months, symptoms may resolve and the patient goes into a latent or what we call the asymptomatic phase. Usually at this asymptomatic phase, they do not produce any kind of symptoms, but the patient may still be capable of transmitting it to others through the insect bites, okay, or blood transfusion as well. So for the chronic phase of Chagas disease, this is manifested by fibrotic reactions that causes injury sa ating heart or myocardium. May also affect the cardiac conduction network and enteric nervous system. So for sa signs and symptoms, the main organ that is usually affected by your Trypanosoma cruzi is your heart. Okay, this leads to cardiomegaly or increase in size of the heart, congestive heart failure, thromboembolism, just like here on this picture. So nakakaroon ng several or diffuse blood clots surrounding the vessels of our circulatory system. Arrhythmias may also be present in patient with having congestive heart failure or with improper heartbeat. So non-specific signs such as dizziness, okay, palpitation, and chest pain may also be felt by the patient, especially at the chronic stage of the disease. So for the specimen of choice, we can use the blood as the most common acquired sample for patient, especially for acute type of Chagas disease. In chronic, we can use CSF, tissue samples, and lymph fluid, okay, to check for the presence of amastigote and trypomastigote, okay, usually seen in the bloodstream and other fluids, especially in the tissues of our heart. So for acute phase, the recommended procedures are GEMSA stain blood smear. This is usually done for the first 2 months of the disease, and this highlights the presence of trypomastigote present in the blood smear. Microhematocrit is done to check if the patient is at risk of having thromboembolism or blood clots, okay, formation of blood clots. So this checks the hematocrit level of the patient. For blood culture and PCR, these are the diagnostic tests and may identify specifically the causative agent of the trypanosomiasis. Xenodiagnosis is helpful in studies or epidemiological studies where we let a vector, usually a redovid bug, to feed on the suspected infected person. So if the redovid bug acquired the trypomastigote, these particular bugs, after being killed, okay, and checking for their fluid under the microscope, we can identify that the patient is rather infected with the disease. Okay. So for chronic stage, we use serological and immunological testing such as ELISA and PCR, indirect heme agglutination tests, and indirect immunofluorescence tests. So for the treatment, the drug of choice for the acute phase is nefortimox and benzimidazole. For chronic phase, this is a case-to-case basis where symptom-specific management should be done in the patient. So, depende kung ano yung signs and symptoms ng patient. So, kung may heart problem siya, yung target natin is the heart, okay? Any kind of treatment to prevent heart attack and heart problems. So, kung there is involvement in the CNS, it's better also to do specific management or signs and symptoms management with regards to the CNS involvement. For prevention, very the same. Use of insect repellents, fine mesh screens, and spraying of houses and building is one of the best preventions of our to prevent trypanosoma or Chagas disease. So we're done with Trypanosoma cruzi. So let's move on to Trypanosoma brucei complex. So this complex is associated with the three types of parasite or Trypanosoma parasite. So your Trypanosoma brucei gambiense, Trypanosoma brucei rhodiense, and Trypanosoma brucei. So let's move on. So for the epidemiology, your brucei gambiense, or let me call it gambiense for short. So your gambiense is more located in western and central regions of sub-Saharan Africa. So most of the time, for Trypanosoma brucei complex, all of these are located or geographically distributed in the continent of Africa. So for gambiense, this is more common in western and central Africa. For rhodiense, this is common in East Africa. And for brucei, this is a zoonotic disease, usually affects the cattle, okay, also in the continent of Africa. So, for parasite biology, kindly take note that there are only two types of morphological forms seen in the life cycle of the parasite, your Trypanosoma brucei complex. So, the first one is epimastigote, which is usually found in the vector, and trypomastigote, which is also the infective stage as well. So this is usually found in the bloodstream of people infected with the particular parasite. So the life cycle of our Trypanosoma brucei complex is usually acquired via the bite of an arthropod vector. So very similar, but their target organ is very generalized. Okay? This usually affects the blood, tissue, okay, of lymph and spleen, and CSF as well. Vectors are considered to be flies, okay, or specifically tsetse fly under the genus Glossina. So these are blood-sucking flies, okay, usually found in Africa. The infective stage is still metacyclic trypomastigote, and the diagnostic stage is trypomastigote. So kindly take note of these particular stages. So here is the life cycle of Trypanosoma brucei complex, or what we call the African trypanosomiasis. So just like the other life cycle, a vector, which usually takes a blood meal, okay, injects a infective stage. The infective stage is trypomastigote in the bloodstream or tissues of the patient or person. So this trypomastigote will enter the bloodstream, okay, and are carried to other sites of the body, such as your lymph fluid, spleen, okay, or in the bloodstream in general. Now, also in the bloodstream, this trypomastigote will multiply by binary fission. So as you can see, there is a difference in your Trypanosoma brucei complex life cycle. And that difference is that they don't need to invade the particular site or tissues or cells, okay, to create a mastigote form. So as you can see here on this life cycle, they do not have a mastigote stage, okay? The trypomastigote is already the one that can multiply by binary fission. Now, this trypomastigote, after multiplying, will circulate in the blood, okay, during acute phase, and are usually, okay, taken by the vector during another blood meal. So the Chacha fly takes a blood meal which harbors the trypomastigote present in the bloodstream. Now, the trypomastigote will transform into procyclic forms. Okay, this is the forms that are usually seen in the vector. And the procyclic form or trypomastigote will multiply again into binary fission. Now, this procyclic trypomastigote will transform into epimastigote and travel the salivary gland of the Chacha fly. Now, this epimastigote will transform into metacyclic trypomastigote to become infective again after or during blood meal, okay? Once the particular Chacha fly infected or taken a blood meal, okay, again in a suspected person. So let's go to the pathology of our Trypanosoma brucei complex. So the general pathology is also known as human African trypanosomiasis, or more commonly known as African sleeping sickness. So as I have said a while ago, your brucei complex is divided into three several species. Your Gambiense is more commonly associated with the chronic type of African sleeping sickness or human African trypanosomiasis. So 95% of all the cases is associated with this particular parasite, your Gambiense. For Rhodesiense, this is the least common, usually constitute to about only 5% of all the cases. But this is the acute type, okay, and the deadlier type of trypanosomiasis, okay, especially African sleeping sickness. So for brucei, this is usually associated with zoonotic infection, okay, usually cattle and other ruminants or grass-eating animals. So this is a table that I actually included in your outline. So kindly take note that the causative agent for each particular cause of African sleeping sickness. So for Rhodesian, or what we call the African sleeping sickness, the causative agent is Rhodesiense. So based on the species name. Okay? For Gambian, this is associated with Gambiense, of course. So for the timeline, as I have said, your Rhodesiense is acute type of African sleeping sickness. So the signs and symptoms may be presented, okay, as early as weeks. While for Gambian sleeping sickness, the signs and symptoms may be manifested, okay, usually months or years. For the cases, 5% is usually associated with the Rhodesian sleeping sickness, while 95% or the most common one is for Gambiense. For trypanosomal chancre, later on we'll be discussing this, more commonly associated with Gambian sleeping sickness. So here is the initial lesion created by Trypanosoma brucei complex. So this is what we call your trypanosomal chancre. So this trypanosomal chancre is a local and painful pruritic erythematous chancre. So this is basically an ulcer, just like your other, just like the created, okay, ulcers of your Leishmania. So very similar. There is a presence of a chancre or lesion located at the bite site, which progress into a central eschar, just like here on this picture. So nagkakaroon ng central crater surrounding the bite site, which resolves at around 2 to 3 weeks. So this is usually acute in appearance or acute in signs and symptoms, and depende dun sa immune state ni patient, they may resolve on their own. So these are more common, your trypanosomal chancre are more common on Gambian sleeping sickness or African sleeping sickness. So just take note, of course, in your outline that either Gambiense and Rhodesiense may undergo stages of African trypanosomiasis. So both of them still undergoes this type of stages. And we have two. We have the early and late trypanosomiasis. So let's talk about first the early trypanosomiasis. So this is also known as hemolymphatic stage. And this is where the parasite proliferate in the bloodstream and lymphatic system of the patient. Usually, patient experiences irregular bouts of fever all throughout the day, headache, joint and muscle pain, malaise or general discomfort all throughout the body, and most of the time for patient infected with specifically Trypanosoma brucei gambiense, they usually develop what we call the winter bottom sign. So the posterior cervical lymph node are enlarged and non-tender and usually rubbery in consistency. So usually this is painless and are more common in Trypanosoma brucei gambiense infection. Okay? Take note of the winter bottom signs. So the signs and symptoms usually manifested within the acute phase or the early phase is due to tissue damage and immune complex production of our body. Usually, this is done or due to the cause of the presence of parasitic toxins or immune complexes reactions that target other organs or red blood cell. So, usually, this particular stage lasts for 1 to 6 months depending on the immune state of the patient. So the next stage is what we call the late trypanosomiasis or meningoencephalitic stage. So this stage marks the involvement of your CNS or central nervous system. So the parasite, have already invaded the brain and meninges of our central nervous system. Usually this occurs at around 3 to 10 months for Gambian infection or Gambiense and weeks only for Rhodesiense. So as you can see, this marks the yung kanilang progressiveness for each parasite. Again, for Gambian or Gambiense, this usually manifests at around 3 to 10 months, while for Rhodesiense, this manifests at around as early as few weeks. So usually, signs and symptoms that are manifested by the patient is according or in relation to neurologic symptoms. So apathy or lack of interest, behavioral changes may also be observed. Headache, sleep pattern changes as well. And during the late stage manifestation, somnolence is very evident. So somnolence is a medical term to describe patient with increased likelihood of going to sleep, okay? Of more often. So parang tayo lang, okay? So ayan, kung lagi kang antukin, okay, in Tagalog, or likelihood to sleep more during the day, this is what we call somnolence, and this is represented by late-stage manifestation of late trypanosomiasis. Deep coma is more common, especially at late stages, and even death. Okay? Take note also in late trypanosomiasis, Carandel sign, sorry na doble lang yung sign. Okay. Pakitanggal. Okay? So, Carandel signs may manifest as a deep delayed hyperesthesia. So this is delayed bilateral pain out of proportion to the extent of tissue injury. So ano nangyari dito? So when we say hyperesthesia, this is the increase in one of our senses. So in case of African late trypanosomiasis, the sense is usually touch. Okay? When we say delayed, so that means if you pinch a person, in fact, during the late stage of late trypanosomiasis, they usually have a delayed reaction. So after a few minutes or a few seconds, dun pa lang nila mararamdaman, or that's the only time that they will feel the pain. Okay? Hence the term delayed hyperesthesia. So that eventually follows either from the disease itself or from the intercurrent infection due to immunosuppression. So this particular patient are at risk of having secondary diseases due to the presence of immunosuppression, or nagkakaroon na ng decreased immune system within the body of the patient. So hence the name African sleeping sickness. So technically you're really will be sleeping Okay, one of the signs and symptoms is through desire or increased desire of sleepiness. So for the diagnosis of our Trypanosoma brucei complex, the specimen of choice is chancre fluid. This is more common at the early stages of the disease. Lymph node aspirate is common in early to mid stages, while CSF is more common sa ating late stages, especially for people with CNS involvement. Kindly take note also that blood is also another specimen of choice. I forgot to add it on the particular slide. So kindly take note that blood can also be specimen of choice, especially at early stages of the disease. So the screening test, the first one is your GEMSA blood stain or GEMSA blood smear stain, especially for early stages or hemolymphatic stages. This is more commonly for rhodesiensis since this is the acute type of trypanosomiasis. Another thing that we can use or screening test that we can use is what we call the Buffy coat concentration method. This is usually extracting the parasite in the Buffy coat of the patient. This is more commonly associated for low infection. No? I will show you a picture later on for Buffy coat concentration. And also the card agglutination test for trypanosomiasis or CATT. So later on, we will show you this particular screening test. So here is the Buffy coat method that we are talking about. So I believe you already know this, especially in your MLSP subject. This is the blood, okay, after centrifugation. So after this particular method, the plasma will be at the top, okay, the serum part. The Buffy coat will be in the middle, which usually contains the different types of white blood cells and even the parasite. So this is the area where we usually extract these particular parasites, especially in the blood sample of the patient. So as you can see, if the patient has a low infection, this is more helpful, okay, to extract specifically the parasite. So here is the card agglutination test for trypanosomiasis. So this is a test card, usually appear as blank circles, just like here on this picture. So usually we put 1 drop of blood here, and then along with the test kit, there is also provided antigen. Okay, this is checking for the antigen, checking for the antibodies created by our body against the antigens for Trypanosoma brucei complex. Now we drop 1 blood of sample here, and then another drop of the reagent, which is usually the antigen. Now, if our body or the serum sample of the patient contains antibodies, there will be presence of agglutination, okay? Just like here on this well 1 or sample 1. So as you can see, the presence of agglutination is connoted with having a dirty looking appearance. So this is the agglutination reaction that we are looking for. So this is a positive result for our card agglutination test kit. So usually, this indicates that the patient has an antibody against the antigen. So nagkakaroon ng immune complex or agglutination, okay, process. So negative is number 6. So as you can see, the presence of agglutination is not visible. So that means the patient do not have antibodies against the antigens of our reagent. So when it comes to the late stages of trypanosomiasis, the only procedures that we can use would be diagnostic testing using your immunological and serological experiments or procedures. So ELISA and PCR, indirect heme agglutination test, indirect immunofluorescence, and mini anion exchange centrifugation technique. So all of these may be associated with diagnostic procedures for the late stage or chronic stage of our African trypanosomiasis. So for treatment and prevention, the drug of choice for early stage of African trypanosomiasis is intravenous suramine sodium and intramuscular pentamidine. For the late stages, especially in cases of CNS involvement, intravenous melarsoprol is more useful. For prevention, vector control and using of insect repellent is the most common way of prevention to prevent the spread of our African trypanosomiasis sickness. So that ends our discussion for hemoflagellates. So if you want to read more, you can use Medical Parasitology in the Philippines by Belisario at pages 116 to 128. So thank you and have a great day.